You're watching CTOM TV. Knowledge is power.
So now we're briefly going to cover indicators of a lack of response.
Okay.
So when we see these, we think, okay, well, even though this patient has high PD-1 or high tumor mutation burden or this or that, that would indicate a response, why are they not responding? And so some of those, we have a list of those. And so one of them, so these are all negative prognostic features. Mutations in a gene called STK11.
Okay. All right. Now, just before you get into this, somebody could have some of these, but some of these that we've just covered.
And this is typically what we see.
Okay.
Yeah. So knowing your genetics.
Right.
Super important.
Okay.
So yeah, STK11 mutations, they result in a lack of response. Mutations in P10 gene, and P10 specifically when you have both copies of the P10 gene. So you know we have two copies of every gene on the most basic simplistic level.
Right.
Some genes have multiple copies, but we have two different alleles. So you know one allele theoretically from your mom and one from your dad. Now it's a lot more complicated than that, but you know sometimes you get both alleles from mom and sometimes you get both from dad. So you have two copies of your P10.
Okay.
Typically, if one is mutated, you'll have the other copy rescue it, and it's a tumor suppressor, so you'll still have some P10 activity, and you know it won't be all lost.
Okay.
So when you have loss in both copies of it, or mutations in both copies of it, then you're unlikely to respond well to PD-1 inhibitors.
Okay.
Another signaling pathway called the Mtor. When you have mutations in the Mtor pathway, then that can be problematic too. It can reduce chances of responding. KRAS mutations. When you have mutations in the KRAS oncogene, and what most mutations in the KRAS oncogene tend to do is they increase the amount of T regulatory ones. So these are the CD4 positive helper cells that the tumors tend to hijack.
Got it.
You know, they start out with the best of intentions, they're helper cells, but they get hijacked by the immune system.
Sure.
So, hijacked by the tumors, sorry.
And so if you have a KRAS mutation, that's more likely.
It increases these Tregs.
Got it.
Versus the TILs. So you want low Tregs, high TILs. Mutations in the EGFR gene and also the MDM2 gene, those can be very bad because if you take a PD-1 inhibitor such as pembrolizumab and you have EGFR mutations or MDM2 mutations, it will actually cause the tumors to grow faster.
Oh boy.
Yes.
So here you are thinking you're doing the right thing.
You think you're doing the right thing and boom, your tumors are increasing in growth.
Wow. More common than people
know. Exactly. So
but that's it. If I can interrupt, that's why
you need to have your tumor DNA sequencing.
But yes, for sure. That is absolutely true. And what I was going to say is that's why there's so much confusion on the part of medical oncologists as to whether these drugs work or not. Is because
they're not looking deep enough.
That's right. And on the surface, it would seem like, okay, if you have this mutation, it's a given, no go, or immunotherapy isn't all that great. And in reality, there's so many factors that you could determine before you took this drug.
Exactly.
And then
then you'd know.
Yeah,
if you're wasting your time or not.
Yes, or making things worse or better. Yes.
So there's also estrogen ER expression. So if you have high ER expression, this tends to lower PD-L1.
Okay.
Now, also I mentioned mutations in NF1. They're a positive prognostic feature for squamous cell cutaneous, but if you have non-small cell lung cancer, they prevent yours from responding. So they're a negative prognostic feature.
Wow, interesting.
Mutations in the CD79A, but that's specific to non-small cell lung cancer, not to other cancers. Loss of the JAK1 and 2 genes, JAK. Mutations in B2M gene. Mutations in the signaling pathway or excessive signaling of what's called the Wnt pathway, WNT.
Right.
That is a pathway that is involved in stem cells. It was
Mm.
first discovered because it creates a type of fly that has no wings,
Mm.
and that's what it's called, wingless.
Oh, interesting.
Yeah, Wnt signaling beta-catenin pathway. So that actually reduces TILs.
Mm.
So when you have overexpression of Wnt signaling, it reduces the TILs, somehow affects the TILs.
Mm.
And it also reduces benefits if you have MSI high, microsatellite high, in colorectal cancer. So let's say you have MSI high colorectal cancer and your doctor says, hey, you'd be a perfect candidate for immunotherapy. Make
Right.
sure you know what's going on with your Wnt signaling pathway
Right.
first. Otherwise, you'll waste your time.
Right. And money sometimes,
And money,
depending on if you have to pay.
Yeah, and before this information came out, we had a patient that had all of the indications, colorectal cancer patient. And she was supposed to respond. She had all of the perfect indications for response. And she didn't get much of a response from it. We're very shocked.
This was
Unfortunately,
years ago.
Yeah. And what we later realized is, oh, well, she had alterations in her Wnt signaling pathway. And so when we looked back, just recently, when I saw this data, I looked back and said, I wonder if that would have explained, when I saw this data, I said, I wonder if this will explain why, she didn't respond. And sure enough, she had alterations in that pathway.
Wow.
So had we known that information, then we could have, gone in a different direction.
Right. Yes.
Yeah.
Thank you for watching Ctome TV. Subscribe below and stay informed.